I'll talk a bit about autoimmune and paraneoplastic conditions. So these are our CAR, MAR, and autoimmune retinopathy. So CAR, or cancer-associated retinopathy, this is a widespread retinal degeneration as a result of cancer. Patients can develop autoantibodies, which include an anti-recoverin antibody. And these patients can often get a rapid loss of central and peripheral vision, along with photopsias and a ring scotoma. In the fundus, they can show arterial narrowing and sometimes some late pigment alterations. And they can have a really severe reduction in the ERG signal, even with a relatively normal fundus appearance. This can be seen in small cell or oat cell lung cancer. And the key here is to really suspect this in patients who are older than 50 years of age, who present with any kind of progressive nyctalopia and visual field loss. MAR is melanoma-associated retinopathy, and it's very similar in its appearance. It may also have an electronegative ERG, which can help distinguish it from CAR. This is typically seen on the isotopic ERG to maximum intensity flash. And interestingly, you can get a similar looking ERG findings and clinical presentation reported with nasopharyngeal carcinoma as well. Autoimmune retinopathy will resemble CAR and MAR, but in it, there's no identifiable malignancy, and patients may have antibodies. The final paraneoplastic condition that's mentioned in this chapter is BDUM, or bilateral diffuse uveal melanocytic proliferation. These are patients who have these multiple melanocytic choroidal lesions, posterior subcapsular cataracts, and they may also have iris cysts and an exudative RD. This is a picture of a patient who developed CAR. You can see that there's some vascular attenuation and very minimal pigmentary changes. This is a picture from a book where there's a patient that has BDUM. These are fairly good photographs of these multiple elevated hypopigmented lesions or choroidal lesions. And this is in a patient who had retroperitoneal adenocarcinoma. This is a fairly uncommon condition. There's a few dozen cases, I believe, in the literature. So it's not one that we should expect to encounter very often. So that finishes the first category. Move over to the metabolic disease category right now. And again, if you have any questions, we'll take some time later on to address those, but feel free just to unmute yourself and ask directly as well. So the first of the metabolic conditions is albinism. This is a condition where we have a reduced or an absent melanin biosynthesis. Tyrosinase is the enzyme affected, and it's really the rate-limiting enzyme responsible for the production of melanin. There's oculocutaneous and there's ocular albinism. So oculocutaneous will involve the eyes, skin, and hair, typically autosomal recessive, whereas ocular will only affect ocular pigmentation. Typically, it's X-linked recessive. And in this, few cases show some fundus pigment mosaicism and some partial iris TIDs as well. These patients may or may not have congenital decrease in vision and nystagmus. Typically, there'd be a hypoplastic fovea, if so. They may also develop photophobia, iris transillumination defects, and fundus hypopigmentation. In patients who do have some tyrosinase function, tyrosinase positive patients, the pigmentation may increase over time. And on the VEP, one thing to know is that single eye stimulation will result in an asymmetric occipital response. There's a greater number of fibers of decusate in patients with albinism as compared to those who do not. Here's a picture right from the book about a patient with a significant drop in hypopigmentation. Also on the right there, there's a demonstration of foveal hypoplasia. Two important conditions to think about whenever we talk about albinism, especially in terms of Royal College and all that, is Chilaiditi and Hermansky-Pudlak. So, Chilaiditi is a group of patients who can have neutropenia, they have deficient platelets, and are susceptible to infections and therefore have a high risk of mortality. Hermansky-Pudlak are patients often from Puerto Rico who have a platelet defect, easy bruising, and bleeding. The take-home point for this is any patients in whom you suspect significant hemorrhaging or who develop multiple infections, consider a hematology consultation for these patients. CNS abnormalities is a long list of conditions, and the book goes through all of these in a lot of detail in a table, but I'll touch on a few of them now. So Batten disease, or neuronal steroid lipofuscinosis. This is a condition, and these are, by the way, these are almost all autosomal recessive conditions. This condition, you get an accumulation of these waxy lipopigments, steroid and lipofuscin, within lysosomes of neurons and other cells. You can get dementia, seizures, vision loss, and a pigmentary retinopathy. There's different kinds of Batten, and typically it's the infantile and the juvenile types that will be linked with the pigmentary retinopathy. A-beta lipoproteinemia. This is a condition in which we get, basically it's apolipoprotein B is not synthesized, and it's a fat malabsorption condition. Therefore, we get vitamin deficiencies of fat soluble vitamins, and which can lead to retinal and spinocerebellar degeneration. A quick mnemonic is the letter A, so A-beta lipoproteinemia is a problem with the function of apolipoprotein B. You can get acanthocytosis in red blood cells, and I've got a photograph coming up with that. And vitamin A supplementation may be helpful, although we have to monitor serum levels. Vitamin A deficiency, you can also see nyctalopia, and you can develop these diffuse drusen-like spots. This is typically seen in patients who are obese, who have gastric bypass surgery, or patients with Crohn's disease who undergo a small bowel resection, and you get a malabsorption of fat soluble vitamins. This can be reversed before degeneration develops, but if there's already degeneration, it may not reverse even with treatment. Peroxisomal disorders. Again, these are conditions that involve a dysfunction or an absence of peroxisomes. There's multiple, they're in the book, they're in a table. Think of things like Zellweger syndrome, which is fatal in infancy, and neoadrenal leukodystrophy, which is often fatal in early childhood by age 7 to 10 or so. Refsum disease, we touched on a bit before, but this is a condition in which you get elevated serum phytanic acid. These patients can develop pigmentary retinopathy, they can have ERG changes, cerebellar ataxia, neuropathy, hearing loss, cardiomyopathy. The key here, the dietary restriction of phytanic acid and phytanic acid precursors can slow or stabilize the neuropathy and the cardiac disease, but does not typically affect the retinal degeneration or hearing. Infants who have this often will have a slight elevation of phytanic acid levels. The adult onset type of Refsum disease often have very high phytanic acid levels. And key foods to think of avoiding to restrict phytanic acid in the diet are dairy products of any kind, cheese of any kind, and some meats and fish and ruminant fats also. Mucopolysaccharidosis, again, it's a little bit out of the scope of this talk, but these are things like, Hurler, Shea, Hunter-Sanfilippo. In these conditions, you have an excessive metabolic products which are stored in lysosomes, and this can lead to a pigmentary retinal degeneration. Tay-Sachs disease is the most common ganglioside disease. In it, we see a deficiency of hexosaminidase A, and you get an accumulation of glycolipid in the brain and retina, and often early death by age 5. Gaucher is a condition that you get a deficiency in beta-glucocerebrosidase, and you have this material that accumulates in the liver, spleen, lymph nodes, and elsewhere in the body, but also in the eye. You can get a cherry red spot, and you can have some OCT hyperreflective lesions visible on the retinal surface. Niemann-Pick, I don't get into too much detail, but there's different types. You can get a cherry red macular halo. And finally, Fabry disease, you get alpha-galactosidase A defect. This is excellent. This is different than many of the rest. Ocular signs for Fabry will include corneal verticillata, tortuous conge vessels, tortuous and dilated retinal vessels, and lens changes. In this condition, you get a material called ceramide trihexidase that will build up in smooth muscle vessels in the kidney, skin, the eye, CNS, and heart. So that's a lot of material for one slide, but these are all in the book. I just want to have a brief exposure to them as we move on. This is a picture of acanthocytosis, which is seen in A-beta lipoproteinemia, as well as other diseases as well. On your top left, you have a path slide of some regular, normal-looking red blood cells. Main picture, you see some acanthocytes. These are cells that have these sort of atypical projections on the outside border, and this is due to an abnormal lipid membrane in these cells. Here's a picture of a cherry red spot. This is a patient who has Tay-Sachs, a young child. And of course, perhaps not so much in a young child, but Does anybody want to think of what's a quick differential diagnosis for just a cherry red spot in general?
No.
Okay.
Anyone want to volunteer? Maybe PGY 2s or 3s?
No. Yes, I is busy right now.
Well, I'll move on. So things like CRAO, of course, trauma or commotio retinae, and then other metabolic causes like gangliosidosis, cellulosis, and even PIC. So here's a picture of a patient with Gaucher disease. And so these white material lesions that you see on the fundus photographs and the hyperreflective lesions you see on OCT are actually accumulations of glucosylceramide in the inner retina. And here's a quick photograph from your BSc book. On the top, we see some corneal whorls in Fabry disease, and the bottom we see some retinal vascular tortuosity. So moving on, cystinosis is a condition in which we get an intralysosomal accumulation of cysteine. There are 3 types. There's a nephropathic type, there's a late onset type, and there's a benign type. They're all autosomal recessive. And in this condition, you can see crystals in the cornea, in the conj, and also in the retina, but typically only in the nephropathic type do we see retinal crystals. Patients can have renal failure, growth delays, renal rickets, and hypothyroidism. You can get patch RPE depigmentation, also some fine crystals. There's often no significant decrease in vision. And the treatment can include cysteamine, which there's oral and different types of eye drops with cysteamine. And the diagnosis would typically be made by a urinary examination, and also looking for cysteine levels of PMNs and also some gene tests as well. Finally, moving on to TPEO spectrum. This is chronic progressive external ophthalmoplegia. This is a condition in which patients have a slowly progressive inability to move their eyes and their eyebrows. Typically, we think of it as a mitochondrial myopathy. Mitochondria are abnormally shaped and they're increased in number. And on pathology, we see these ragged red fibers, and these are visible in these pictures here. Typically, you'll see them on a trichrome, so a Mason trichrome or a Gamori trichrome stain. And what the ragged red fibers are clumps of abnormal mitochondria. And it is associated with atypical retinitis pigmentosa. Kearns-Sayre syndrome has a classic triad of CPEO, pigmentary retinopathy, and cardiomyopathy, cardiac conduction deficits. The pigmentary retinopathy with these conditions is typically best seen on fundus autofluorescence. It doesn't always have that drastic an appearance on fundus examination. Only rarely will it have typical bone spicules or panretinal degeneration. These patients can retain good vision and retinal function. So that summarizes chapter 13. It's a lot of information and not always easy to summarize, but are there any questions that people have regarding that before we move on to chapter 14? So I'll move on, and we can talk about questions at the end if anybody has any. Chapter 14 is a summary of drugs that have toxicity to the retina. And it breaks it down fairly well into 7 categories. There's 3 anatomic sites and then 4 sort of other findings that can be noticed. So first of all, I'll talk about RPE and toxicity, then vessels, so occlusive retinopathy and microvasculopathy, then the ganglion cell and optic nerve area, and move on to drugs that can cause macular edema, drugs that can cause a crystalline retinopathy, those that cause color vision or ERG changes, and finally some less common miscellaneous conditions as well. So first, RPE and photoreceptor complex toxicity. The drugs that are talked about in this chapter are chloroquine, Tylenol, phenothiazines, clofazimine, desferoxamine, NRTIs, MEK inhibitors, and alkyl nitrite. So chloroquine and Plaquenil, of course, have been in the news quite a bit this last few weeks. The name is Arolen. This is an anti-malarial. It's also used for amoebiasis, rheumatoid arthritis, lupus, and more commonly used in Europe, South America, and Asia. Ocular side effects and retinal side effects I'll discuss differently in all these different drugs. So in terms of ocular effects, you can get decreased vision. You can have corneal yellow-white opacities and whorls, which with chloroquine typically do not have a relationship to posterior segment disease. You can get transient macular edema as well. In terms of the retina, the drug binds to melanin in the RPE, so you can get a sort of an RPE granularity on the early side, and then later on this can develop into a full-blown bullseye appearance with RPE thinning and clumping. You can get peripheral fine granular pigment changes, vascular attenuation, abnormal sensory testing, scotoma, and sometimes a color vision defect. Blue-yellow would be early and red-green would be late. Plaquenil, similarly, is an anti-malarial, which is also used for RA and lupus, more commonly used in North America and in the UK. Ocular effects are similar, so decreased vision, corneal opacities, and whorls. With Plaquenil, these are a potential indicator of posterior segment toxicity to distinguish it from chloroquine. The retinal effects are very similar, so a perifoveal RPE granularity, which can develop into bullseye maculopathy, peripheral pigmentary changes, and the same color vision defects as well. I know you had a really good grand rounds on Plaquenil just recently, so I won't spend too much time on it, but here's a picture of your classic bullseye retinopathy. Just to note, this is often seen, it can have a different appearance in different patients. So Asian patients will often have a much larger area and maybe have say a 7 to 15 degree affected area of the bullseye, whereas for patients who are non-Asian, often this is a much smaller central macular region of maybe 3 to 4 degrees on each side of the fovea that begins to get affected. The toxic maculopathy may be reversible only in very early phases, and the macular changes can progress even after the drug is stopped, often for some time. Hydroxychloroquine has a much lower incidence of toxicity, and the goal is to really screen for early relative scotomas, which sometimes may be reversible if the drug is stopped. Late changes like color vision loss, absolute scotomas, and decrease in vision. The risk of this approaches 1% after 5 to 7 years of use, or after a cumulative plaquenil dose of about 1,000 grams. So in terms of screening, I think this was addressed very well in the recent grand rounds, but typically patients may have a baseline examination within the first year of use or not, and typically annual screening after 5 years of use is recommended. Often in clinical practice, patients are screened annually for 5 years, and then annually or biannually as per their factors following that. Subjective tests include a history of vision changes, AMS or GRID, which is maybe less useful these days. Color vision testing, which is the same. Humphrey Visual Field 10-2, focus on pattern deviation here, especially a central or a repeatable paracentral defects about 6 degrees from fixation or further in patients who are Asian. The objective tests here are full eye examination, OCT, autofluorescence photographs, and multifocal EMG. This is a picture. The top there shows the progression over 4 years or so of a pericentral visual field defect in the patient. B, the fundus looks relatively normal, but on C, OCT, you can see, I'm not sure if I have a cursor here, but right over here and right over here, but more so on the temporal side, you see just a little bit of a decrease in the ellipsoid layer and the outer retina. This is the early findings of the UFO sign that can sort of indicate the onset of a bullseye maculopathy. This is a table that talks briefly about factors that increase the risk of chloroquine and plaquenil retinopathy. Interestingly here, we look at the total duration of use, more than 5 years, the cumulative dose, so for plaquenil, more than 1,000 grams total. And this is an older table, so the daily dose here that was talked about was in terms of the ideal body weight, so more 6.5 milligrams per kilogram for plaquenil and more than 3 milligrams per kilogram ideal body weight for chloroquine. There's some new evidence that looking at a dose greater than 5 milligrams per kilogram of real body weight may be more accurate and more helpful. It's always important to consider pre-existing retinal disease, such as macular degeneration. I always tell patients who have AMD who are taking plaquenil that not only may plaquenil perhaps increase their risk of having, not only may the AMD perhaps increase the risk of developing plaquenil toxicity, but it also makes it more difficult to diagnose. So take care and have caution with patients who are using these drugs with coexistent retinal disease. Patients who have an ABCR mutation may also be predisposed to these toxic effects. Moving on to phenothiazines, this is chlorpromazine and thioridazine. These are drugs used for psychosis, so depressive, involutional, senile, or organic psychosis, and schizophrenia, and other things as well. The ocular effects of these medications include decreased vision and accommodation, night blindness and color vision problems, corneal pigment deposits, subcapsular dust-like lens deposits, or stellate anterior cortical cataracts in chlorpromazine. The retinal effects include pigmentary changes and macular edema, which is rare and really only with long-term therapy. Here's a picture showing a chlorpromazine-related anterior cataract. And here's a picture showing a fundus photograph and fluorescence showing RPE atrophy secondary to thioridazine. And so you get this sort of modeled RPE atrophic appearance in the right eye. As a class, these drugs are fairly widely used and they're very safe overall, but with prolonged use, the rate of ocular effects can reach 100% by up to 10 years. Thioridazine is more likely to cause retinal effects than chlorpromazine, and we think of using it in ophthalmology, say perhaps with using retrobulbar chlorpromazine with without alcohol for chronic blind eyes with pain, ocular pain, inflammation, or corneal ulcers, and this works through denervation. Desferoxamine is a drug we'll probably encounter perhaps a bit more often. It's an iron chelator. It can cause two things. It can cause macular RPE changes, which can be either a reticular or more of a vitelliform appearance. And it can also cause macular edema, which is typically due to RPE pump failure. The bottom you see a photograph which shows a patient that has foveal RPE pigment clumping due to desferoxamine use. The NRTIs are nucleoside reverse transcriptase inhibitors. These are medications that are used for HIV. They inhibit HIV viral replication. Ocular effects include, side effects include mitochondrial toxicity, and they can damage tissues with high oxygen requirement. And in regard to the retina, these patients can get a bilateral, symmetric, and mid-peripheral modeling and atrophy of the RPE and choriocapillaris, which is best seen on fundus autofluorescence. MEK inhibitors are drugs that are used to treat a number of metastatic cancers. They inhibit mitogen-activated protein kinase enzymes, MEK1 and MEK2. And the retinal effects of these include a multifocal serous retinal detachments, which oftentimes one will involve fovea if the patient presents with a drop in vision, but not necessarily. And on the bottom here, we see on the left, there's arrows indicating all the different locations of these serous elevations. And the left, you see the elevated subretinal fluid with the fovea. This is similar somewhat to CSR, central serous retinopathy. Of course, we think of steroids in CSR, and steroids are often an exacerbating or a causative factor for CSR. And patients who present with a serous retinal or foveal detachment always ask about steroids. Ask about other things besides oral. Ask about steroid skin creams, inhalers, and nasal sprays, because oftentimes patients will have a history of previous use, if not using them at the present time. Sildenafil, we'll talk about a bit later on, but it's been linked with CSCR as well. And this is because of the choroidal vascular dilation and congestion it can cause. Alkyl nitrites are an inhaled drug used for their euphoric effects. They can rarely cause a toxic maculopathy, which may or may not improve over time. The bottom there, we see a photograph of a patient who has maculopathy. If you look right beneath the foveal depression, there's some disruption in the inner segments in the ellipsoid zone due to alkyl nitrite use. So now move on from RPE to vessels, and these are drugs that can cause an occlusive retinopathy or a microvasculopathy. The drugs that we will discuss are interferon, ergoalkaloids, contraceptives, procainamide, and aminoglycosides. So interferon alpha, or intron, is a drug that's used for viral hepatitis, chronic blood diseases, and various malignancies. It can cause changes in vision. It can cause a non-specific conj reaction, cause ocular pain and visual effects. But with the retina, it can cause retinal ischemia. It can affect both large vessels and capillaries. It can cause non-perfusion, cotton wool spots, hemorrhaging. Patients can maintain good vision, and the onset is variable. It can range from as early as 2 weeks to as late as 3 months. And it's seen in between 1 and 30% of patients, so a fairly wide range. But it may recover when they're still on the drug, or especially if the drug is stopped. Here are 3 photographs of patients. You can see these patients have interferon-related vascular toxicity. So there's hemorrhages, there's cotton wool spots. In the middle photograph, we see some scattered axoplasmic debris, almost like a Purcher's-like retinopathy. And on the right, we see a CRVO-like appearance. These are all due to interferon alpha. Ergoalkaloids. Here we're talking about ergotamine and dihydroergotamine. These are drugs used for migraines. They constrict arteries and veins through direct stimulation of cerebral smooth muscle. And the retinal effects can include thrombosis, which can involve retinal veins and arteries becoming occluded. Here's a picture of a patient who has a CRVO, which is secondary to ergotamine use. Moving on to oral contraceptives, there's a number of these, various estrogens and progesterones. They're used for amenorrhea, dysmenorrhea, uterine hemorrhages, gonadism, and for oral contraceptive use, of course. The ocular effects can include decreased vision, contact lens intolerance, and eyelid and corneal changes. But with the retina, we can often see thrombosis, including retinal vein and artery occlusions as well. So here's a patient on the left we see who had a venous stasis retinopathy picture, who was taking an OCP, and she progressed to have a non-ischemic CRVO. Procainamide. This is a medication that is related to lidocaine. Remember, there's with local anesthetics, you have your amides and your esters. This is an amine analog. It's used to treat treatment-resistant ventricular arrhythmias. Ocular effects can include photosensitivity. It can also include myasthenia and lupus-like symptoms. Retinal effects include a retinal vaso-occlusive disease secondary to procainamide-induced lupus, in which you can see pruning of the second-order retinal vessels and arterioles. So here's a picture. These are different patients that show basically a zonal retinal whitening due to vascular ischemic disease, causing, as you can imagine, very severe vision loss. Moving on to aminoglycosides. Specifically here, we were talking about historical use of intraocular amikacin and intraocular gentamicin. These are not typically systemic administration, and they were previously used to treat endophthalmitis. These are bactericidal antibiotics. They inhibit protein synthesis. With regard to the retina, they can cause macular infarction, a severe macular ischemia, and irreversible central vision loss. These drugs have a very narrow therapeutic window, which is important to consider. Here's a picture of a patient with retinal whitening, hemorrhaging, severe necrotizing obliterative retinopathy, causing an inferior detachment, which is what the arrows indicate there. This slide is not in the book. It's a slide on HORV, which is hemorrhagic occlusive retinal vasculitis. This is a relatively newly discussed condition that's rare, devastating, and it's typically seen as a complication after cataract surgery in which vancomycin was used. These patients can have a delayed onset of their findings, but they develop retinal hemorrhages, vascular non-perfusion, and they have a significant risk of neovascular glaucoma and blindness. These patients will often present with vision loss, but with a quiet eye, no pain, and perhaps only a mild posterior uveitis. And they can have very poor outcomes, often 2100 right down to NLP. This is a picture from a recent article that shows a patient. If you look at the top, you see the right eye and the left eye are affected in different degrees. The left eye has a very severe retinal hemorrhaging, and on the bottom, especially, you can see the left eye has almost a complete obliteration of the retinal arterial supply. The right eye has relatively preserved posterior pole vasculature, but obliterated more peripheral vasculature. This can be a very deadly disease. So moving on now from the vessels to drugs that can affect the ganglion cells and the optic nerve. So the two discussed in this section are for quinine and methanol. So quinine is a muscle relaxant. It's used for nocturnal cramps. It's used for myasthenia congenita and for some kinds of eyelid myokymia. The ocular effects can include decreased vision, which can be transient or permanent, pupillary changes, and you get optic nerve papilledema or pallor or atrophy, depending on the stage, as well as color vision abnormalities that can result as a secondary feature. Retinal effects can include retinal edema, degeneration, pigmentary changes, and you can also develop a cherry red spot that mimics CRAO, as well as ERG changes. This is a patient here that shows bilateral optic pallor and atrophy. There's bilateral peripapillary vascular ischemia. These can be acute, or they can, acute and permanent, and typically seen not with regular dosage, but with an overdose of quinine. Methanol is an alcohol. Often it can be used for certain industrial purposes. Patients can ingest this, of course, and effects can include acute blindness. These patients have an acute transient optic nerve head edema, macular edema, and cell death. Often they'll develop optic atrophy and retinal vascular attenuation, and they may often have an electronegative ERG. This is a slide of a patient who had ingested methanol, showing the acute optic atrophy that can result. Moving on now to macular edema. These are drugs that can cause macular edema. The drugs discussed are taxanes, like paclitaxel, docetaxel, nicotinic acid, glitazones, and fingolimod. So paclitaxel and docetaxel are cancer chemotherapy drugs used for a variety of tumors, including breast carcinoma. They are microtubule inhibitors. The retinal effects can include an angiographically silent CME. So this is CME that's visible clinically and on OCT, but not visible on fluorescein angiography. And the edema will typically improve once the drug is discontinued. Here's a picture of a patient who had this. On the left, you can see some subtle changes in the central macula. The IVFA in yellow there in the middle does not show much in the way of leakage, but on the OCT on the right, you can see this prominent cystoid macular edema present in this patient in both eyes. Nicotinic acid or niacin is a cholesterol lowering agent. This can also cause an angiographically silent CME, visible both clinically and on OCT, but not on fluorescein. And similarly to paclitaxel and docetaxel, the edema will improve once you stop the drug. This is a patient who had that, so a similar fundus appearance, no significant leakage or very minimal leakage seen on fluorescein, and on the OCT down below, you can see there's some cystoid macular edema cavities present.
Dr. Dorrepaal, I think a question.
Yes, of course.
From Kayla Clark, so I'm just going to unmute you now. Yeah, go ahead. Kayla Clark, go ahead.
Hello, can you hear me?
Yes.
Yeah.
Yes, I was just asking with respect to the, I know you both mentioned the tamoxifen, and then the docetaxel, and you also mentioned chloroquine. I know is sometimes you can have issues with them both. Is there something with the method of action? Because I noticed you mentioned macular edema, but the hydroxychloroquine doesn't really present in this sort of fashion. So, but they usually say when you paint bullseye, you should try to avoid using those two medications. I was just wondering if there's a different appearance when you use them both.
I'm not aware, and perhaps if anyone else is, they can chime in. I'm not aware of a difference in appearance of different kinds of bullseye maculopathy, but I will talk a little bit about that, I think, later on in the talk as well. So maybe that will help bring it together a bit.
Okay, thank you.
So I'll move on to glitazones. So these are oral hypoglycemics for diabetes. Here we're talking about lactose. These can have a systemic effect, which can include severe fluid retention and pulmonary edema, and the retinal effects can include macular edema as well. Here I'll talk about desferoxamine. This is a slide that we already went through, but just a reminder that desferoxamine, which can cause macular RPE changes, can also cause a macular edema. again, due to RPE pump failure. Fingolimod, or Gilenya, is a drug that's used for multiple sclerosis, typically the relapsing remitting, and it's the first oral agent available for this purpose. For the retina, we have a syndrome called FAME, or fingolimod-associated macular edema, which is more commonly seen in patients who have uveitis and diabetes than those who do not. Typically, this can be treated by stopping the medication, although there is some evidence it can also be treated using steroids, even when the medication needs to be continued. Moving on to crystalline retinopathy. This is a category of conditions in which we can see crystals deposited in the back of the eye. The drugs discussed here are tamoxifen, canthaxanthine, methoxyfluorine, and also a plant, kola nuts. So tamoxifen is a selective estrogen receptor inhibitor. It is used as an adjuvant therapy following primary treatment for breast cancer, commonly used. And in regard to the eye, you get a decrease in vision and corneal opacities. Retinal effects can include these inner retinal yellow or white superficial opacities crystals, outer retinal punctate gray lesions, macular edema in some patients, as well as a possible central ellipsoid band disruption. And going backwards here. Here's a photograph and OCT of patients. The top left, we see there's these extrafoveal tamoxifen deposits. Top right, we see there's some parafoveal CME. This is sort of a mid to late phase IVFA. And the bottom, we see a central disruption and some loss of the ellipsoid layer in the outer retina, visible right underneath the fovea. Here's another photograph, fluorescein and OCT of a patient with tamoxifen toxicity. So we see the crystals up top. There's some changes on the fluorescein, but specifically looking at the OCT at the bottom, we see a fairly pronounced defect in the outer and foveal retina. Canthaxanthine is a cosmetic drug. It's used to simulate tanning, and the effects of it can involve crystalline deposits in all layers of the retina. And if used at a sufficient dose to get the desired effect, 100% of patients will develop this. I haven't seen it myself, but apparently it's commonly seen if this drug is used. And these are patients here showing a fairly pronounced and fairly prominent crystalline retinopathy present as a result of canthaxanthine use. Methoxyfluorine is a drug that's used or used to be used for anesthesia. It's no longer used. It had the side effects in the retina of intravascular crystalline oxalate deposits in patients with renal dysfunction. Here's a picture of a patient and of their progression from multiple cotton wool spots to sort of pronounced deposits of methoxyfluorine and partial resolution of this over a six-month time period. Kola nuts are a West African caffeine-containing nut of the kola evergreen tree. The effects are benign, but you get these inert yellow-green inner retinal crystals, which can be seen in the fovea and parafoveal areas. This is a picture of the kola nut on your left there. We see the crystals on the photograph on the right in the parafoveal area. And again, these have very visible clinical, very minimal impact on vision. And here is just all the green areas are parts of the world in which kola nuts can be typically found. So mostly Western Africa, a little bit in Turkey, and also in some in California as well. Here is a table I just took right from the book. This talks about the causes of crystalline retinopathy. So think of not just drugs, but think about systemic diseases, hyperoxaluria, primary oxalosis, cystinosis, Sjogren-Larsen syndrome. The drug-induced causes we've talked about already, so tamoxifen, canthaxanthine. Think of things like talc emboli in patients who have chronic IV drug use, methoxyfluorine, triamcinolone injections. So often you'll see crystals on, not in the retina, and West African crystalline maculopathy with long-term colon net ingestion. Also think of ocular conditions like Vieti atrophy, calcific drusen, which can mimic this type of crystalline retinopathy, gyrate atrophy, and macular telangiectasia, which often will have these parafoveal sort of crystal-like deposits as well, in association with the other findings that you see. Things to think about checking in patients who present with crystals in the retina are oxalate levels in the urine and in plasma, electrolytes, urinalysis, and cysteine levels in PMNs or in cultured fibroblasts. Moving on now to patients that develop color vision and ERG changes. The drugs here are PDE5 inhibitors like sildenafil and tadalafil, digitalis, isotretinoin, and vigabatrin. So the PDE5 inhibitors, Viagra and Cialis, these are drugs used for erectile dysfunction. And in addition to inhibiting PDE5, they can also act on retinal PDE6, which is an enzyme that can lead to reversible color discrimination problems, blurred vision, glare, and blue vision, blue tinted borders between light and dark areas, as well as some ERG changes. As I mentioned before, there's also a link between strokes and central serous retinopathy. I don't believe any permanent toxic effects have been reported, but it can be quite visible to patients when they're undergoing this. Moving on now to patients who use digitalis or digoxin. These are cardiac glycosides. They're used for congestive heart failure and AFib. The retinal effects can have a yellowing vision, xanthopsia, a yellow tinting of vision. Isotretinoin or Accutane, this is a drug used for acne. This can cause poor night vision and nyctalopia in some patients who can have an abnormal dark adaptation curve, as well as some ERG changes as well. And finally, vigabatrin or Sabril. This is an anti-epileptic often used in kids. Retinal effects from this can include visual field constriction and ERG abnormalities. Finally, the last category is miscellaneous. Here we'll talk about rifabutin, acetazolamide, topiramate, and silver. So rifabutin or mycobutin, this is an HIV drug used in HIV patients as prophylaxis against co-infection with MAC and other infections. The retinal effects will include a uveitis, which can be anterior, intermediate, posterior, or pan. Patients may have a hypopion or hypotony, and it can resolve with steroids and, of course, with stopping the rifabutin. Here, a picture shows a patient who has a fairly widespread retinal and vitreous hemorrhage. The arrow points to an area of intermediate uveitis, and there's also some vascular ischemia. Diamox or acetazolamide is a fairly commonly used medication. It's used as diuretic for edema, elevated IOP, of course, we all know that, but also for altitude sickness. And in it, we worry about the induction of myopia, chorioretinal folds, macular edema, ciliacoidal effusion, and possibly even acute ankle closure glaucoma. So here's a picture of a patient. These are the retinal folds you can see in a patient with Diamox. Topiramate or Topamax is an anticonvulsant. This drug is typically can typically cause induced myopia classically. Also can get chorioretinal fold, macular edema, effusion, and acute ankle closure glaucoma. This is a picture of a patient that presented with AC shallowing and choroidal effusion, seen in the B scan in the middle there, top and bottom of the photograph. Silver, there really is probably no good reason to ingest it, but patients sometimes will. And systemically, you can get algeria, you can get ocular pigmentation, you can get black tears. With retina, you can get a dark choroid appearance with these leopard spots, which are caused by granules in Brooks membrane, as well as some drusen-like deposits. This is a picture I took right from the book showing argyrosis, or this sort of silver deposition in the conjunctiva of one eye. And that brings to a close. So we've talked a bit about systemic associations in chapter 13, drugs, or not drugs, but conditions that involve retinal degeneration, as well as metabolic disease. And in chapter 14, drugs that involve the RPE, vessels, ganglion optic nerve, macular edema, crystalline retinopathy, color vision, ERG, and a few others. So it's a lot to go through, and it's not always easy to keep it all straight, but I hope that was helpful. I'd be happy to answer any questions anybody has at this time. I'm new to Zoom, but I'm going through the chat here just to make sure I'm not missing.